And with the microphone, if you could turn off your microphone, and there will be an opportunity for any questions at the end of the webinar, but please feel free to send any questions using the Q&A icon on the top of the Teams menu throughout the presentation, and I'll pick those up at the end of the webinar. Thank you. So some introductions is my name is Paula and I am GBUK's Export Account Manager, and this is Wendy, who is our Enteral Product Manager. So let's go through the agenda today. So we'll go through the agenda. It initially starts with the background. Forgive us, we're just letting some more people in. Perfect. So some the agenda. Go back onto the agenda. We're going to go through some background on why we're doing today's webinar, and we're also going to go through the pH questionnaire that I shared and the summary of our findings. Then Wendy will go through the pH presentation, where we'll look at the clinical advantages of use of pH in clinical practice, the economical advantages versus other tests, how to overcome main concerns about this technique, and we'll also look at the practical advantages of the pH reader. You'll also have an opportunity to see the products being demonstrated, and then we have a guest speaker who's joining us, whose name is Gareth Bannister from the Royal Wolverhampton NHS Trust, and then we'll have some time at the end of the webinar to go through some questions and answers. So let's begin. Let's go through some background on why we're doing today's webinar. So as an account manager and my colleagues, we'll be speaking to our distribution partners, who in turn speak with their clinicians, to understand what method is used to confirm nasogastric feeding tube placement. And we found that pH testing is not commonly used throughout the world as a method to do this. And when we look at the questionnaire, we will see that the most common method, which has its flaws, could result in never events, which are events that shouldn't happen. For example, feeding into a lung. Now, so the point of today's webinar is we're going to explore the pH method in more detail. We're going to evaluate the pros and cons and how the cons can be overcome to help you understand why this method could be used in your hospitals. So let's go on now to our pH questionnaire and summary of our findings. So some of you may have seen our questionnaire and completed it, so thank you for that. And some of the questions that we asked was, what method is used in your hospitals to confirm tube placement? We also asked, with the method that you use, what difficulties that you may experience. And we also asked if you'd ever had the opportunity to use the pH method, as well as looking at the cost of x-rays in your hospitals to see which is more cost effective. And what we found is that the most commonly used method to confirm placement is the ascitation method, which you guys will probably know it as the Whoosh test, which is closely followed by the X-ray. Now, feedback from our participants reported difficulties when using the Whoosh test to establish the placement this way, because it was unclear if they were hearing air in the lower lung as opposed to the stomach. So that, of course, could result in potential never events. Now, of the participants who completed the pH questionnaire, participants that had used the pH strips did report the following challenges. They were concerned about difficulty obtaining stomach aspirate, and also some anxiety around reading the strips accurately, as well as some patients who may be using H2 blockers or proton pump inhibitors, which of course alter the stomach aspirate. And we'll look at these in Wendy's presentation in today's webinar. We also gathered information on the cost of the x-rays, and we found that it varies from country to country, but the range is between £70 to £150. So after today, you'll be able to see the cost implications versus pH. So I'm now going to hand over to Wendy, who is going to go through the use of our pH in clinical practice in assessing placement of NG tubes. To Wendy.
Thank you. So yes, as Paula says, I'm going to talk about the use of pH in clinical practice is a useful tool for assessing the placement of NG tubes, but also for using testing pre-feeding as well, prior to feeding with NG tubes. So I'm going to look at the placement of small bore nasogastric feeding tubes and the incidence of errors when this occurs, and also the characteristics of what a good bedside test for testing pH should be, a good bedside test for testing position of tube should be, and what are the clinical advantages of pH testing. Also, I'm going to look at the clinical disadvantages of pH testing, particularly the ones that you all mentioned in your questionnaires, and why pH testing we think should be the standard for bedside testing. So first of all, just a few statistics to start with. An NG tube, as you know, can quite easily enter the trachea instead of the esophagus. And I looked at some studies worldwide with figures on this, and there were 3 large studies that were carried out in the United States and Brazil. And it included over 12,000 patients in the study, and it was reported between 2 and 3.2% of tubes inadvertently were inserted into the respiratory tract. This is tubes that were inadvertently inserted into the respiratory tract, but not necessarily the patients were fed through these tubes. Now, in some countries, it's mandatory to report this, and in other countries, it isn't mandatory. But in places like the state of Pennsylvania in the United States and in the United Kingdom, it is mandatory to report these events when the tube is placed into the wrong place and enteral feed is administered to the patients. So in Pennsylvania, between 2011 and 2016, there were the 5-year period, there were 56 undetected misplacements where patients had feed administered over a population of 13 million patients, 30 million people. In the United Kingdom, over the same period, with a population of 65.5 million people, there were 95 undetected misplacements, and enteral feed was administered to those patients. And that, we know, is about 780,000 placements of tube a year. That's roughly how many tubes are placed in the UK over 5 years. So it's still a significant problem. And in both those instances, some of those patients died. So what characteristics should a good NG tube placement test have? Some tests are just suitable for initial placement, and they tend to be the more expensive ones that are on the market. Some tests are suitable just for pre-feed testing, and other tests are suitable for both initial placement and pre-feed testing, and obviously would be very cost effective because of this. When you consider a test for NG placement, the considerations must be the test must be accurate. You must know that you're getting an accurate result from the test that can show you demonstrate that the tube is in the patient's stomach. The test must be fast, because if a test takes too long, then that can delay the patient's feeding, which could obviously have consequences for the patient. It must be easy to use with minimal training. It's important that these tests are quite easy to use, because they're going to not just be carried out by healthcare professionals, they're also going to be carried out by people in the community. So from the home, for example, parents caring for a child. The test is used, so it must give reliable tests. It must also be complete. Tests that have to be sent off for a laboratory, for example, to give an additional result are going to delay the process of feeding, the process and the feeding of the patients. But it's also very important because these tests are carried out on such a regular basis, especially when pre-feeding testing is carrying out as well. They need to be very cost effective. So what common tests are there? The most common test worldwide is probably the X-ray, and that's used on initial placement across the world. In America, for example, the X-ray is the first choice test for confirmation of the initial placement of the tube. However, in Europe and Australia, more commonly, they favour the pH test, with X-ray only being used when pH fails. And obviously this is useful because the patient does not get exposed to as much radiation as they would if they were automatically X-rayed after initial placement. So testing pH, as we're going to find out, is probably one of the more common methods. Respiratory distress is an indicator of the insertion errors. So when a tube is put into a patient, if it goes into the patient's lung, then the patient is likely to show signs of respiratory distress. However, this doesn't always happen, especially if you have an unconscious or semi-conscious patient. Even in some conscious patients may not show signs of respiratory distress. So not the most useful test.
The Whoosh test, as Paul has described, is the most commonly used around the world, where air is infused down the NG tube and a stethoscope is placed over the patient's stomach, and you listen for the bubbling sound. But again, it's difficult to know exactly where that sound's coming from. There are other tests such as bubbling and aspirate appearance, and also the litmus paper test, which is a test which is probably the forerunner of the pH test, where blue litmus paper will turn pink in the presence of acid. However, blue litmus paper turning pink will also happen at a pH of around 6, possibly even 7, so it's not a good test for stomach pH. For pre-feeding test, all of those methods, apart from X-ray, are used for pre-feeding as well. So these are the most common tests that are used around the world. There are also other methods that are available simply for initial placement testing. And these are usually carried out away from the ward environment or using very specialist equipment within the ward. So, for example, biochemical markers. It could be that a sample of the patient's aspirate is sent to the laboratory for further testing to establish where the tube is placed. So that would inevitably delay. Ultrasound is not necessarily useful for all patients because depending on the patient's anatomy, whether it's quite easy to see the tube being passed down the patient's esophagus. Electromagnetic tracing shows a 3D avatar using quite an expensive tube and some other expensive equipment that needs quite a high level of training to be able to use. And again, only useful for initial insertion. Other techniques such as visualization, which is like a camera that's used again on quite an expensive tube, and things such as capnography or colorimetric capnography, which just means monitoring for expired CO2, so expired carbon dioxide, which you shouldn't get when a patient has got an NG tube in situ. So these methods are all used for initial placement, but not necessarily useful by the bedside and definitely not useful for pre-feed testing. So X-rays. X-rays, the most commonly used method around the world for establishing when the tube is first inserted that it's in the correct position. It's currently the gold standard around the world, and you can see the tube in the patient's stomach. However, X-raying can be problematic. It can be that some NG tubes, for example, are of a poor quality and don't show up very well on the X-ray. Some X-rays are difficult to read because of the patient's anatomy as well. And interestingly, the majority of patients who have incidences of misplaced tubes that are fed inadvertently into their lungs in the United Kingdom, the statistics show they are these days as a result of misread X-rays. So they are two of the reasons that could occur. This can also lead to a delay in feeding because you wouldn't feed until you knew the tube's in the right place. And obviously, X-rays can also be quite a high cost. From our survey, we discovered that the cost of an X-ray can vary between about $75 and $150 around the world. So do all patients need an X-ray, or is there a better method? So of the bedside methods, I've got capnometry at the end there because there is a bedside method that's been developed for using that. However, there's only really pH that is able to fulfill all of the criteria that we discussed earlier that the ideal test should have. So it's accurate, fast, easy to use, reproducible, complete and cost effective. Of the non-bedside methods for initial placement, there's none that are suitable at all for pre-feeding checks, and many of them are obviously suitable for initial placement checks, and all of them have been shown in tests to be highly accurate, but all of them have some difficulties in use and require quite a lot of training. So none of these are going to be useful for both initial and pre-feed testing. So pH testing itself, the normal human stomach has a pH of approximately 1 to 3 on an empty stomach and 4 to 5 after food has been eaten. In a normal healthy patient, the lungs are between 7.38 and 7.42. This can be increased with pathology of the lungs. Patients who are on acid-reducing medication may have stomach pH of 6 or above. So they're the sort of criteria that we're going to be looking at. So why was pH testing introduced as a standard in the UK? In 2009, the UK declared, the UK NPSA declared that misplaced nasogastric tubes and feeding of the patient became a never event in the United Kingdom. And they stated when they introduced pH reading as a result of this is that while none of the existing bedside methods for testing the position of nasogastric feeding tubes is totally reliable, there's evidence to suggest that a pH reading of between 1 and 5.5 can reliably exclude hormone replacement of the nasogastric tube. And so that's setting the criteria at 5.5 when we know lung pH is above 7. You're never going to get a result that tells you can safely feed a patient when it's in the patient's lung. So clinical advantages of pH testing. It's safe and clinically effective, but it's very important that the pH test strips that you use are actually CE marked or gastric aspirate, and that means they're quality assured and they're tested specifically for use on humans. They need to be accurate and fast with minimal training. They need to be reproducible, complete and cost effective, as we've discussed before, and our pH strips are able to conform to that. So clinical disadvantages of pH testing. One of the things that people mentioned on our questionnaire was difficulty in getting aspirate, as well as the influence of proton pump inhibitors and H2 antagonists in feed and medication, which alters the patient's stomach pH. So they're the two main things that people notice. But in addition to that, there is also colour blindness because strips are red reading coloured pads. Ambient light deficits. So if the light is not good, the strips being read in, that can influence the reading of the strip, and also inter-user disagreement and anxiety. So some users report that they get quite anxious when they have to carry this out, and if the policy is locally that 2 people need to read the strip, then that can cause some inter-user disagreement. But if the problem is difficulty getting aspirate, generally, the statistics seem to suggest between 18 and 42% of the time it is difficult to get aspirate. Now, this seems a very, very high figure. However, with a few remedial actions, it is possible usually to get aspirate on most patients. One of those things is quite simply, for example, if a patient's been just fed by their NG tube for some time, it may be that they're not really producing much in the way of gastric juices on an empty stomach. So just by giving the patient oral care, that can actually stimulate the gastric juices to flow. So giving some oral care, leaving it for a few minutes, 10 to 20 minutes, and then testing again, you may well be able to get some. Another consequence may be that the tip of the tube is actually sitting outside of the pool of fluid in the patient's stomach, and simply by changing the patient's position, so turning the patient on their side, and this particularly helps with children, turning the patient on their side can help to dip the tip of the tube into that pool of gastric juices. Other things that can be done is the tube could be advanced a little or just pulled out a little, just to ensure it dips into the pool. So they're the sort of things that you can do on a regular basis. One of the other measures that you can take is if the tube is buried within the folds of the patient's stomach, you can inject just a little air, which will stop any blockage of the tube by the stomach folds and allow it to dip into the pool of the gastric juices. So there's lots of things you can do if you can't get aspirate from the patient's stomach to be able to achieve this. And most of the time, the statistics show that that is actually achievable. When it comes to PPIs or H2 antagonists, talking to different people in different hospitals in the UK who have policies on this, there's several different ways to work with this if this is a problem. If a patient doesn't have a safe swallow, it's suggested that stopping the infusion of the PPI receptor or the H2 antagonist for about 30 minutes prior to the test, or testing as long as possible after the administration of those drugs, can help to achieve a favourable result for feeding. If it's feed that's running and it's continuously running, stop for an hour prior to carrying out the test. And again, you should be able to get gastric juices to get a good pH test from those.
In some hospitals in the United Kingdom, they have adopted a policy of saying if a patient is on PPIs or H2 antagonists, to set a limit of a pH 6. So the limit is a little higher than it would be in a normal patient. Because they know the patients are on PPIs, then they set the limit at 6. And with lung pH being above 7, this should still be a safe level to feed where that decision has been made. Balancing the effectiveness as well of the PPIs when a patient's being given formula feeds and reviewing their use on a regular basis on balance against the need to feed. And finally, if a patient does have a safe swallow, a last resort is that you can give a patient a drink of an acid drink, for example, or fruit juice, and then aspirating that to test the pH to establish that what the patient's swallowing is going into the patient's stomach, and you were able to aspirate that from the patient's stomach to check the correct position. So this would all form part of a decision tree that you can use in order to safely use pH on patients who are having PPIs to reduce their stomach acid. So disadvantages of pH papers. So just moving on to the other disadvantages we mentioned, colour blindness. A lot of people are colourblind and don't know it. And with the indicator strips, they rely on coloured pads. However, many people, whilst they may perceive colours differently because of colour blindness and may not be aware of it, they can usually distinguish between shades. And when testing was done on the pH strips, many people disagreed on individual pH strips, but were able to say what the overall result was accurately of the pH strip, because they were able to get one or more colours correct. Ambient light defects, as I've said, particularly as a nurse myself, I know that when you're on night duty and you're trying to read one of these strips by a very poor lamp at the head of the patient's bed, it can be very difficult to read these strips. And also, as I mentioned earlier, inter-user disagreement and anxiety can lead to some difficulty in reading the results. And the answer to that really is to automate the process. And by automating the process, you take out those human factors. And to automate the process, in 2020, Bapen came out with the following statement in their position paper: where pH is used, automated pH readers should eliminate the intra-observer error in reading pH. So to take all of the human error factors out of it, we should automate that process. So characteristics of a good pH test paper. As I mentioned earlier, it needs to be CE marked for testing human gastric aspirate. Preferably, they should have 3 pads for reading, and this is partly for the reason that I gave earlier of different people perceiving colours in different ways on the three different colour pads. But also it means, unlike some competitor products where there is only 2 pads on the strip, they cannot be read accidentally upside down because you have 3 very distinct colours. It's also important to have a strip that does not bleed and its colours remain stable once the strip has been soaked in the aspirate. They also need to be buffered against sterile water. Without going into this in great detail, sterile water will appear more acid than ordinary water will. And because sterile water is often used in the most vulnerable patients to flush the NG tube, if you aspirate and get some sterile water flush into that aspirate, it can potentially give a misleading result. So our pH strips are buffered against water, and as I say, without getting too technical, it recognises the ions within, and as it recognises the ions within, it will give a realistic pH that the water should be of 7. So they should also have, because they need to be cost effective, they should also have wide-ranging storage conditions and long dates, which are products. So how are they used? It's very simple. Place a sample of the aspirate on all 3 colour pads. We wait 10 to 60 seconds for that colour to stabilise until there's no further colour change, and then we match the strip to the colour chart on them. So that's when they're being used. So why use the pH exact reader? It's to automate the process and increase the accuracy of the process. In tests, in the critical point of a pH of between 5 and 6,
When users were reading the strips, they were getting a 94% accuracy for the strips, and that's in the most critical area between a pH of 5 and 6. When using the device was 100% accurate in this critical area. So it will take the anxiety out of the process, it will take the human error out of the process, and it's 100% effective at that critical. So why is pH testing preferred in many countries for testing NG tube position? And it's this: the pH test will reliably give a safe result for feeding. Thank you.
Thank you, Wendy. So we're now going to do a demonstration of our pH strips being manually and also on our exact reader. So I'm just going to hand over now to the demonstration. Thank you.
Attach a large purple ventral syringe to the NG tube and gently pull back the plunger.
Just for a second, we're just going to change the camera so that it's focused on the unit. Will just be one moment. Perfect. Thank you. And continue.
Okay, so take a large purple ventral syringe to the NG tube and gently pull back the plunger of the syringe to withdraw gastric content from the stomach. Remove the syringe when you have enough stomach content to cover 3 pads, and attach the cap of the NG tube to stop the stomach content from leaking. Remove one strip of pH paper from the tub and reseal the container before covering each coloured pad with fluid. Wait up to 60 seconds until the colours have stabilised. We have one we prepared earlier to use for this demonstration. Line up the strip with the colours on the enteral pH tub to verify the correct pH number. All 3 colours must match up. You can get a second person to review the results as well if you wish, if your local policy this is mandatory. pH on this patient is measured at 4, which shows the aspirate to be acidic and therefore safe to read. Alternatively, the strip can be read more easily and accurately using the pH exact reader. The reader can be used in the hospital as well as the home setting. The pH exact reader has been shown to be more accurate in testing than user analysis alone, and unlike user readings, are not subject to poor light conditions, inter-observer disagreement, differences in eyesight, or colour blindness. The pH reader was switched on and the device will self-test on booting up. Strips should be tapped on a paper towel to remove excess aspirate, then laid on the carrier of the strip reader. The carrier will detect and draw the strip into the machine, where it is able to read the pH without interference from light outside the machine. Information that can be entered prior to the reading include batch number of pH strips and patient ID number. The device confirms that the reading of this patient's pH aspirate is 4.
It's 4.
Lovely. A printout confirms the reading and can be signed and filed away for future use. The device can keep up to 200 records and can transfer the data for safekeeping on a PC.
Wonderful. Thank you for demonstrating that. So we now have our guest speaker who will join us. So if just wait for Gareth to be entered into the room. But just to introduce Gareth, thank you for joining us. Gareth is an adult registered nurse who's worked for the last 8 years in nutrition, both in parental nutrition and also enteral nutrition in both the private sector and the National Health Service. Gareth's current role is a nutrition nurse at the Royal Wolverhampton Hospital Trust, and that has 3 hospital sites and also a large number of community tube fed patients. So, hello, Gareth, how are you?
Hi there, I'm fine, thank you, Paula.
thank you very much for joining us today. We really appreciate it. The reason we wanted to speak with you is just to understand your experience of how you confirm nasogastric tube placement. So the first thing that I wanted to ask you is what method are you currently using to confirm feeding tube placement?
So currently in the trust, we use a 2-person check using pH strips only, and we work on a range of 5.5 or below. However, I'm aware that obviously other trusts might use a slightly different or slightly lower level. The WUSH tests, as you already sort of like mentioned, that might be used elsewhere, they've been not actually permitted in the UK since 2005, I believe, since the NPSA alert. If we're unable to get a pH on the first insertion, we try a number of methods, as Wendy has already mentioned, to try to get a pH, and if all else fails, then we will resort to X-ray on that occasion. And we also utilize the decision tree, as you mentioned before, where the situations where there's a high pH or we're unable to actually get a confirmation. So we do use those on occasions.
Perfect, thank you. And why did you decide to use the pH method? What made you move over to the pH?
So as part of safety, patient safety initiative last autumn time, we looked at all aspects of nasogastric tube management, from pH strips used, the type of tubes, X-rays, everything that's involved with them, stuffing. And a large consideration was the people's colour perception. I believe you may tell me that different on the numbers, but I think there's quite a high proportion of 1 in 12 men and 1 in 200 women, I believe, have colour perception issues. So removing part of that human element was a major factor for selecting this product for the trial. And when we looked at what was around, pH Exact was the most suitable product out there that met our requirements to proceed to testing.
Perfect, thank you. So what are the advantages of the pH Exact reader, and how has it helped on a daily basis in the clinical practice?
So we completed a trial of this, so this is currently going through our procurement at the moment, but the results of the trial really were the fact it's simple to use. It's fast, as I think your demonstrations like showed that. It provides a physical printout of the results for the patient notes if required, so you've got that audit trail in there. The big thing removes any ambiguity over the reading colours. I think you've highlighted that one person might say it's 5.5, the other person says it's 6. That's a critical range. Which one is it? Which one's it safe to go for? Again, Wendy sort of mentioned, lighting, night shifts, colours of curtains around beds, even that, it makes a massive difference. So it gets rid of that sort of like risk element in there. And pH Exact is also more compliant with the criteria of our point of care team than our current method. So it records information both on the paper and in a downloadable format if required, which will help us when we come to further audits.
Brilliant. That's wonderful, Gareth. Thank you so much for sharing your experience and why you guys decided to introduce that and the benefits and advantages that that's had for your trust. And so thank you very much. Now, Gareth, we are going to be moving on to some Q&As. You're welcome to join in with answering some of those questions if you'd like. And that also with Wendy. So I'm just going to now pull up the questions. So everyone, I hope you found the presentation, the webinar useful. So I'm just going to pick up the questions now and aim them at Wendy and Gareth. I won't be a second. So let's have a look. Okay. Currently at this moment in time, I don't have any questions. Maybe that's because we were super thorough and in covering everything that we had in the webinar. But do you have a question, Wendy, that you'd like to ask Gareth?
Yes, I do. Gareth, we were talking about the decision tree for patients with PPIs. What level do you set the pH at for patients who are having PPIs and H2 antagonists?
So we don't actually have a different level for people who are on PPIs. We use a decision tree so that if people are having constant ones, because we would recheck the pH every single time we access the tube. So even if the feed is running and we're doing some medications, we will still follow a decision tree to make sure the centimetre markings haven't changed, there's been no respiratory distress, etc. Yeah. And therefore you may actually expect a higher pH of 6, but our decision trees go through a number of criteria which will actually allow us to continue using that feeding tube without the need for an X-ray. If we've had things like position has moved at the nose, and we get a different pH, then we would move to X-ray. But most of the time we can actually do everything by following the decision tree and using the pHs.
Great, thank you very much. Thank you.
Perfect, thank you. So we've just had a new question that's coming from one of our guests, so thank you for that. So at your trust at the Wolverhampton, do you download the results from the pH Exact reader to a computer? Do you have that? Do you do that at Wolverhampton?
So as I mentioned before, we've done a test and we're currently going through procurement at the moment to actually get these into the trust. So they're not right the way through the trust at the moment. And it would be in a downloadable format at the moment, unfortunately. I think you are working on linking other aspects so it reads to our point of care system automatically, but currently downloadable.
Perfect, you did say that, thank you. And Wendy will pick up on that too.
Yes, there's some software that you need to have to be able to download this, which is available from the company, and it will effectively download it in a spreadsheet that can be saved, so the information can be saved that way. But once the software and everything is set up, it's quite straightforward to be able to download it.
Perfect, thank you. And we have a new question, and I'll ask that to yourself, Wendy, if that's okay.
Yeah.
So in terms of the timing of that you wait for the pH aspirate, we mentioned up to 60 seconds. We have our guest who's asking if you could clarify whether we should wait this full 60 seconds before putting it into the pH Exact reader or reading it. Would you like to expand on that?
The instructions for use for the product say once the colour has stabilised up to 60 seconds or once the colour has stabilised. So if you feel the colour has stabilised, then you can definitely do that. But as a fail-safe, yes, wait 60 seconds if that's the convenient way to do it, and you know that it's not going to change at that point. So yes, that's a good thing to do.
Thank you for all your questions. So we have a new question, and this is for patients that may be in isolation. So how do you use the strips when the patient is in contact or other isolation and can't take the strips with you? Would you like to pick that one up, Wendy?
The strips actually, they're very useful. They come in two different size packs. They come in a pack of 100, and they also come in a pack of 25. So it's quite easy to be able to leave that small pack of 25 with that patient in their isolation room in order to be able to do that. I think it's quite useful that they come in those smaller amounts to be able to do that.
I agree.
Do you anything to add on there, Gareth, at all?
No, I mean, it's slightly different, but we actually found that when we were doing our testing, the actual amount of packets of strips seemed to be reduced because we actually, I say this is talking slightly around it, we had our pH strips by the machine in a point of care room. So rather than having lots and lots of little packets around that would tend to get thrown away at the end of a patient's stay, we didn't get through a huge amount of actual strips during the month-long test that we actually did. So we found it a bit of a saving.
Practical application of it, yes, absolutely. Yeah.
Thank you, Gareth and Wendy. And we have a new question, is at what point do you retake the pH test? Is it each week? Is it each time, when it's clinically relevant? Would you like to pick that one up, Wendy? Gareth, would you like to answer?
So different trusts will have different policies. Here at Royal Wolverhampton, we actually do it for every single time that we're going to administer any feed, flushes or medications down the tube. So we'll do it on initial insertion. If we were then going to be doing the feed 2 hours later, we would do it again when the feed was running. If the medications were due an hour after that, we would again recheck the pH then and follow our decisions tree. So we check it, so we could be checking it 4, 5, 6 times a day.
Perfect. I hope that answers your question. Thank you, Gareth. And then we have another question in terms of the pH, how the pH is measured in the machine and how long it takes to get the results. Would you like to answer that one, Wendy?
How long it takes for the results is virtually instantaneous.
Yeah, we saw that from the demonstration.
Yeah, from the demonstration, you can see that. I know inside the machine that the machine, it cuts out all ambient light from inside the machine. And I think it's a process called photometry, but I will double check this actually, and we can send this answer out to people. It's a process called photometry where it recognises the colour of the strips, but exactly how it works, I'm not an expert, but I will find that out for you. I do apologise. Do you know any more, Gareth? Have you looked into that?
I've got no idea. All I'm just going to know is it's really quite simple and easy to use. Leave that to scientists who develop machines.
Yes.
Thank you. And then we have a new question come in, which asks, is the pH Exact Reader portable? And do you take it on a trolley, and can it be easily moved from bed to bed?
Absolutely, it would fit in my handbag.
Yeah.
Yeah.
Would you agree with that too, Gareth, that it's really
It is
easy to
portable.
take around?
We found on our trial, we did it on quite a large stroke unit, that we actually found by having it in one position was actually beneficial, because that way everybody knows where it is. It's probably the highest, what is the highest usage of NGs in our trust. And if we were to have it on a trolley, it's a bit like everything else. Where's it gone to? Whereas if it was fixed in one point, it was there. It's obviously easier then, because you can quality control it as much as you need to and do our checks that we wanted to do on it. And yeah, it was nice and simple. And the instructions that we had were very simple to have above it.
Super, thank you, Gareth. And our next question is asking, have there been any errors with the machine or any errors with the results? Yeah, do you want to take that one?
Errors with the machine, errors of results, are really tend to be around the strip itself and whether the strip is properly soaked, because if the strip is dry, the machine will reject it. Whether this strip has been put correctly into the machine, whether the carriage is correctly on the machine. The machine's great in that it will say strip's too dry, carriage isn't working properly, things like that. It will actually bring error messages up on the screen, is my experience of it. Do you have any other experience to add to that, Gareth, at all?
It's exactly that. We found it really easy to use. Accuracy was really good. It's sort of like we did comparisons between our existing strips, the new strips, manual readings and that sort of stuff. And we found it very, very good and very accurate, very easy to read. Didn't get any errors happening over the period from what I recall. Staff feedback was good.
Thank you both. So we have another question asking whether it's necessary to set up a baseline measurement before checking the pH of a patient's stomach aspirate. Would you like to pick that up, Wendy? Is that
I'm
about?
not quite sure I understand the question.
I wonder
can
if
see the
it's
question
about.
is,
I wonder if it's about checking to make sure that with the solution that we
solution.
Yeah.
Yeah, there is a calibration solution that you can use with the device to check its calibration on a regular basis, which is a solution with a known pH. If I remember correctly, it's a pH 4. And you would put that on the strip, put it into the machine, and check that the machine is measuring that it's 4. So yes, that is a test that you can do with it on a regular basis if you want to. But as well as that, the machine goes through a series of self-checks and will tell you it's passed, or I hope it's passed its self-check when you first switch it on as well. So I hope that answers your question, Julia.
You. And then the next question we have is again from an infection control perspective, and ask if the pH reader, Exact Reader, is wipeable.
It is, yes. There's instructions within the user manual. It's wipeable, and you would wipe it over with just the same sort of detergent disinfectant wipes that you would normally use in your hospital. The only caution I would say is that with the touch screen, if you use the very soapy wipes, then they can build up a deposit on the screen. So you need to make sure that you keep that screen free of a build-up of the what's left behind from the wipes. So, but yes, you can do that.
Perfect, thank you, Wendy. And we have another question come in asking whether other companies' pH strips could be used in our pH Exact Reader.
No, the pH Exact Reader can only be used with the enteral pH strips, and that's because they have a very distinctive colour scale from other colour scales that are available on the market, and it's recognising specific colours within the machine to be able to test that. So no, it can't be used with others.
Perfect. And then we have a question that we've already discussed, and that was about whether it was possible to connect the results from the machine to the digital patient file. And as we have gone through, is you can connect it. There is software where you can download the results. Do those results then automatically go into the patient's files, or does that is there extra software that would be required?
That extra software would be required, and quite a heavy input from a hospital's IT department to be able to achieve that. In theory, that is possible, but I think on a practical basis, then that probably wouldn't happen. People would just save the information as it's downloaded from the machine. Would you be in agreement with that, Gareth? Is that what you're aiming for?
I'd say that's the current state of play, as I understand it, that we can't make it automatic.
Yeah.
Thank you. Now I'm just refreshing to see if we have any other new questions. So please feel free to use the question and answer icon if you have any questions. Thank you. Is there any questions you would like to ask Gareth? Anything else, Wendy? While we have our guest speaker's time. Thank you.
No, I
No?
think we've covered a
I think
lot
we've
of
covered
ground.
quite a lot.
Yeah.
Wonderful. Well, Gareth, thank you very, very much for your time today. We really appreciate you sharing your experience and of what happens at your trust and also in the NHS. So thank you very much for
Most welcome.
your input, answering the questions too. So thank you.
Of course.
And to our guests, if there are any more questions that you have after the webinar, please feel free to either reach out to your local distributor or to your account manager, and we'll be sure to pick those up. Now from there, we will we'll share the recording of the webinar and share any information that you may have. So thank you very, very much for joining us in our webinar today. Have a fabulous day.
Thank you.
Take care. Bye-bye.